not only the Swedish registry. I'm hoping I will be giving you an overview of the published data.
All the registries.
Some of them already pinpointed by Torsten, so I will do that quickly.
Thank you.
Thank you, Jay. Thank you, Martin. I appreciate being the last speaker is not always very easy, especially if you have odd disclosures to make. For example, being a former Exeter Hip Fellow. I also need to pinpoint that I'm wearing an Exeter Hip tie, which possibly will influence. With that being said, I would like to thank Klaus for the kind invitation, and I have learned quite a lot. One of the things I have learned during this meeting is using Menti. So could you please grab your phones? Thank you for that, Moritz. So you either scan the QR code on the left-hand side or use the code when you go to the homepage menti.com. And Jay, you have already been asking a few questions, which I will be repeating partially, but this will be in a scientific way, I suppose, rather than hand raising. My first question to you is, when are the patients regarded as young? And then you have the option of younger than 55, younger than 30, younger than 20, or younger than the surgeon. It seems to be some small issue. My apologies. There we go. There you are. Because there is, when you read the literature about young patients, there is a discrepancy in the published papers on when you are regarded as young. It seems as if less than 55 is getting more votes. That's good. 30 is coming up. 20 and the surgeon seems to be on the bottom. So with that in mind, I would like for you to grade the statement I would offer THI to a patient younger than 55, 30, 20, the surgeon. So if you vote with number 1, it's absolutely inappropriate, and if you have a 7, then you would definitely consider. Obviously, the patient needs to be in need of hip replacement, so the question should be regarded with matter of that.
And we assume the surgeon is still alive, yes?
Yeah, the surgeon doesn't seem to be an important factor in decision making, which is quite interesting. So thank you for that, and we will be coming back to these parts of these questions at the end of the presentation. In young patients in need of THA, I would use, this is about the fixation. So you could vote for uncemented fixation, cemented fixation, hybrid, other. What might that be? So thank you for that. And then here comes the question about articulation, which we have been discussing a bit during the morning. The COC for ceramic on ceramic, ceramic on poly, other, metal on poly, metal on metal, and resurfacing. Jay, I think you will be doing the resurfacing, right? Yeah. Thank you.
I don't think those people answering resurfacing can read English.
Thank you. So thank you for your answers. A couple of these questions will come back later when I'm done with the presentation. For those of you who are not familiar with national joint registries normally collect data on patient demographics. They do collect surgical data in the majority of the cases. For example, indications for surgery, implants being used, incision and fixation methods. Most of the national joint registries have adopted the collection of patient-reported outcomes, as mentioned by Martin here, during the recent year. Quite a few of national joint registries collect actually data on the surgeons and provide feedback systems to the surgeons, which I think is an interesting way of getting feedback, my personal view. And then it's important to know that data to the national registries is being reported prospectively and analyzed retrospectively. There are obviously limitations with registries, which I'm sure that most of you are aware of, but then I would state that registries actually reflect the real world. It describes to you what happens when you, for example, start using hip resurfacing, in contrary to small cohort of patients being reported on, operated not commonly by experts. So 55 was the first, and this is a report from Elroy. It's a few years ago it was published. They looked into patients less than 55 years. In this publication, almost 20,000 THAs were included. And the main reason was primary osteoarthritis in this publication, and secondary OA was only 33%. The most commonly used articulation was cement on polyethylene, used in 48% of the cases, and the most commonly used surgical approach was posterolateral. 80% were operated using a cementless fixation, 10% hybrid, and 10% cemented fixation. The conclusion in the paper was that the risk of revision in patients younger than 55 years partially depended on surgical approach, the head size being used, and the bearing type. And they also could state that the use of anterior approach resulted in a decreased risk of revision, whereas the use of heads larger than 38 and metal-on-metal bearings had an increased risk of revision for any reason. In this paper from the Swedish Arthroplasty Register, we looked into patients who were 30 years or younger. We did a matched cohort study when we tried to find a control group of patients being older than 30 years, matched on specific factors. So this is the flowchart from the study. We excluded cases operated due to tumors, fracture or trauma, and other reasons which were not specified in the register. As you see, we had 504 patients less than 30 years, and the control group initially was 169,861. And we did the matching based on the gender of the patient, the sex of the patient, the diagnosis, the implant fixation being used, type of articulation, year of surgery, and the femoral head size. So looking into the two different patient groups, patients less than 30 years, uncemented was used in majority of cases. But as you see, there were a few numbers of hybrids and cemented fixation, and oddly enough, resurfacing was used in 6% of these patients compared to 1% to other patients older than 30. We also looked on the articulation being used, hard and soft, and Swedes are extremely conservative. We adopt new technologies quite late. So for this time period, we have been using quite a lot of non-cross-linked poly, as also mentioned by Torsten from the Norwegian or the NARA study. This is also an interesting table. The 5 most frequently used cups was used in 65% of the cases if the patients were older than 30 years, but only 41%. And the difference in the stem side was even larger. You could argue that in younger patients with deformities, you will be using other stems than what you normally use. I believe in that, but I also believe that in our eager to try to improve the outcomes for the younger patients, we sometimes use new implants without proper documentation. The mean follow-up was slightly longer for the younger patients, obviously because they live longer. And the proportion of patients being revised was 11.2% in the younger group and 4.3% in the older group. If you look into Kaplan-Meier survival probability, you see clearly that up until 10 years, it's in the middle of the graph, slightly to the right. The differences are not as large. And as you go by, the confidence interval obviously increases. But you see a clear decrease in the implant survival. So I think one of the reasons we don't capture this in other published data is that we don't have enough long-term follow-up for the younger patients. With time going and with more younger patients being operated on, I think we will be significant differences in the implant survival, obviously. Another interesting finding in this Swedish study was that the patient-reported outcomes preoperatively and looking into EQ-VAS, which is a general health index, was significantly lower in younger patients compared to the older ones. And when you look post-operatively, the difference wasn't there. We could measure a difference in the EQ5D index. So younger patients do have or report more problems, both functional problems, but also pain issues prior to having surgery. And the improvement is almost as large as for the older patients. And I will come back to this in a few seconds. This is the NARA paper. I won't go through it detailed because Torsten already mentioned the paper. But the conclusion from that paper was that both cemented and uncemented fixation seem to be a viable option in this age group, but with a lower implant survival than in older patient groups. This is a quite recent paper from NGR. They looked into patients less than 20 years this time. They included 769 THAs performed in 703 patients. The median follow-up time in this report was 5.1 years. And this is a demographic data on age, so the number of patients at different ages reported to NGR having a hip replacement done in this publication. What they could show that the most common indication for THA was osteonecrosis, followed by osteoarthritis. They report a quite high use of ceramic on ceramic in the NGR report, 57%. Ceramic followed by ceramic on poly, 15%. And as you see, they have cementless fixation in 53% of the cases, hybrid, cemented, and then 10% resurfacing. They tried to do analysis of different articulations, and ceramic on polyethylene had the highest Kaplan-Meier survival estimate at 5 years, tightly followed by ceramic on ceramic. They also looked into the method of fixation, being cementless HA, or cemented non-HA, cementless HA, cementless non-HA, and cemented, and they couldn't find any significant differences with regards to type of fixation. So I was worried about not getting a conclusive answer from you guys, asking you about when the patients are young. And based on many things I have learned, I actually asked ChatGPT about when the patients are regarded as young. And I would like to encourage you to read that answer. So I think we have covered all those age groups according to ChatGPT. But then, partially provoked by Jay today, I feel sorry before doing that, let's go back to Menti. So grab your phone. And give me your answers again. When do you think a patient what would you consider offering a THA in a patient younger than 55, 30, 20? The surgeon. We have 40 answers. I will wait until 55, 60 because we had about 70 answers priorly. This is quite interesting. I don't know if you see the difference here. So, some of you has actually moved to be more appropriate by offering THA to patients younger than 30 and 20 compared to the previous voting. So thank you for that. And then, partially provoked by Jay on method of fixation, I actually did ask ChatGPT to tell me if I should offer a young patient a THA or not. This is a long answer, so I asked him to summarize the response, and this is the response from ChatGPT.
Clear as mud.
So I feel quite happy. ChatGPT basically concludes that the patient needs to see a healthcare professional to discuss whether they should have a hip replacement but also emphasizes what Torsten described. It's extremely important to have a good discussion with the patients and the parents before you make any decisions. So my summary and my understanding is that younger patients generally report worse health-related quality of life prior to surgery, and that might actually be due to us being a bit reluctant offering them joint replacement. Modern THA seems to yield positive outcomes in younger patients, and the choice of articulation and surgical approach may impact the risk of revision surgery, but I would also, based on literature available, noticing that the follow-up is not long enough, state that both cemented and uncemented THAs are viable options for younger patients. With that, I would like to thanks again for this great opportunity of coming to Bern, but also invite you to the International Society of Arthroplasty Register Congress in Montreal in May. Thank you.